Welcome! The Pennsylvania Departments of Drug and Alcohol Programs, Health, and Human Services have prepared this webinar to inform and support local county planning teams and multidisciplinary teams that will identify, assess, and construct plans of safe care for every infant born affected by substance use or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder. This webinar is also the first step in the Governor's Institute for Plans of Safe Care, a two-day work session that will provide local planning teams with an opportunity to come together and develop their local processes for implementing plans of safe care. We'll talk more about the Governor's Institutes at the end of the webinar. Special thanks to the members of the statewide multidisciplinary work group on infants with substance exposure for sharing their expertise, providing input, and working to guide Pennsylvania's support for substance-exposed infants and their families. This webinar will provide some of the basic information you will need to know regarding plans of safe care. We will cover what plans of safe care are, why they are needed, who needs a plan of safe care, who can help support plans of safe care once they are in place, and how to develop and implement a plan of safe care, as well as next steps for all of us. First, let's review what plans of safe care are and why an infant and their family may need one. Plans of safe care are service plans developed by a multidisciplinary team to ensure the health, safety, and well-being of an infant who has been affected by substance use. The plan can include services and supports for both the infant and their mother and other caregivers. The plan can be developed for a pregnant mother whose child may be impacted by substance use, a newborn who shows signs of withdrawal upon birth, or an infant up to 1 year of age who shows signs of substance exposure. Pennsylvania has developed a process for creating and monitoring plans of safe care based on the requirements identified in both federal and state legislation. Plans of safe care will coexist with other plans already in practice in the fields of substance use treatment, medicine, and child welfare, as well as early intervention and intellectual disability services. While plans of safe care will differ from standard substance use treatment plans, hospital discharge plans, and child protective services safety plans in a number of ways, these plans can help to strengthen any plan of safe care put into place. Many of the domains in the plan of safe care come from these three documents. Let's look at some examples of existing service plans and how they compare to a plan of safe care. Substance use treatment plans focus on the treatment of an individual with substance use disorder. Plans of safe care, in comparison, focus on the needs of the affected infant and may include treatment services, but also broader services for the whole family. A hospital discharge plan focuses on the health and well-being of the newborn infant. A plan of safe care certainly focuses on the health of the affected infant, but also may include the ongoing health and development of the infant, as well as treatment needs of the caregiver or family. Finally, Child Protective Services safety plans focus on the immediate safety of a child. Plans of safe care focus both on the safety of the affected infant, but also the infant's ongoing well-being by addressing the health and substance use disorder treatment needs of the caregiver and family. Current research remains too limited to draw any conclusions about the full and long-term consequences prenatal substance exposure has during infancy and throughout childhood, but it is widely understood that prenatal exposure to alcohol and substances has the potential to cause a wide spectrum of physical, emotional, and developmental difficulties for infants. Prenatally, substance exposure is associated with physical birth defects and an increased risk of regulatory and neuropsychological difficulties. For the infant under 1 year of age, some of the impacts may include physical, emotional, and/or developmental difficulties and ongoing challenges in stability and well-being. The Child Abuse Prevention Treatment Act, known as CAPTA, was originally enacted in 1974 and is the United States' foremost legislation addressing child abuse and neglect. CAPTA has been amended several times, with the most recent changes made through the Comprehensive Addiction and Recovery Act, known as CARA, in 2016. This amendment added requirements related to infants who are identified as affected by substance abuse, experience withdrawal symptoms, or have fetal alcohol spectrum disorders. Changes to CAPTA included removal of the term illegal in regard to substance abuse, requiring that plans of safe care address the needs of both the infant and the affected family or caregiver, specifying that data on affected infants and plans of safe care be reported by states to the extent practicable, requiring that states develop and implement monitoring systems regarding the implementation of such plans to determine whether and in what manner local entities are providing, in accordance with state requirements, referrals to and delivery of appropriate services for the infant and affected family or caregiver. Development of a service plan for the infant and their family or caregiver is stipulated in federal law. The legislation also describes the diverse stakeholders that play critical roles in detecting and responding to the needs of these infants and their families and caregivers. In state legislation, Pennsylvania passed Act 54 in 2018 to meet the federal CAPTA requirements. Per this law, mandatory notification to the Department of Human Services is required when a medical professional who is involved in the delivery or care of a child under 1 year of age has determined based on standards of professional practice that the child was born affected by substance use or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder. It is important to understand that notification by a healthcare provider to DHS and any transmittal to the County Children and Youth Agency shall not constitute a report of suspected child abuse by itself. The most notable changes as a result of Act 54 are the removal of both the limitation of notification to DHS of illegal substance use and the exception to reporting if the pregnant woman was receiving treatment for a substance use disorder. Those changes will have significant impact on practice. The requirements regarding notification of infants born affected by substance use go beyond the use of opioids and apply to all infants born and identified as affected by substance use, whether legal or illegal substances. The law also requires the Departments of Drug and Alcohol Programs, Health, and Human Services to develop written protocols pertaining to plans of safe care, which has begun in the statewide guidance document. Let's review key characteristics of plans of safe care that ensure they will be effective for infants and their families. Effective plans of safe care are interdisciplinary across health and social service agencies, comprehensive in their review of the physical, social-emotional, health, and safety needs of the infant and the parents or caregivers, family-focused as they assess and meet the needs of each family member as well as overall family functioning and well-being, and timely in their completion in the prenatal period or before the infant's discharge from the hospital. Effective plans of safe care are also easily accessible to relevant agencies with the appropriate confidentiality safeguards in place, collaborative in identifying lead agencies for plan development, implementation, management, communication, and data submission, and evidence-informed, taking into account practices backed by research, such as a preference that infants, mothers, and families remain together whenever possible. Something to think about. In your local area, is there already a format or template for plans of safe care? Next, we will discuss who needs a plan of safe care in your work with infants and their families. Plans of safe care are required by law to be developed for newborns and infants up to 1 year of age, born affected by substance use or identified as displaying withdrawal symptoms from prenatal drug exposure or a fetal alcohol spectrum disorder. Let's discuss who are partners to help in the development and implementation of plans of safe care, both at the state and local level. There are 3 primary state agencies who partner to develop, monitor, and report data pertaining to plans of safe care: the Department of Drug and Alcohol Programs, the Department of Health, and the Department of Human Services. For each of these departments, different offices at the state and local levels may be a key partner in the work around plans of safe care, such as single county authorities, substance use disorder treatment providers, children and youth agencies, mental health, intellectual disability offices, and medical professionals. In the Department of Drug and Alcohol Programs, resources and partners who can help support plans of safe care include single county authorities and substance use disorder prevention and treatment providers. Single county authorities are the local entities for a catchment area that includes 1 or more counties. There are currently 47 SCAs serving the 67 counties in the Commonwealth. The Department of Health is responsible for planning and coordinating health resources throughout the Commonwealth. It licenses and regulates a variety of health facilities such as hospitals, nursing homes, ambulatory surgical facilities, and other inpatient and outpatient facilities. In the Department of Health, resources and partners who can help support plans of safe care include public, maternal, and child health program providers, hospitals, and medical providers. In the Department of Human Services, here are some of the different offices who can help provide technical assistance regarding plans of safe care. the Office of Children, Youth, and Families, which oversees the state-supervised, county-administered child welfare system, including public and private children and youth agencies, the Office of Child Development and Early Learning, which oversees early intervention services, the Early Learning Resource Centers, and home visiting and family support programming, and the Office of Mental Health and Substance Abuse Services, which oversees county mental health agencies and substance use services statewide. Other Pennsylvania resources for plans of safe care include court systems, such as drug courts, which provide intensive judicial supervision, treatment, and incentives to help support and monitor offenders in substance use recovery, and family wellness courts, which focus on preventing foster care placement by providing services to families with substance use problems who are known to the child welfare system. Other resources may also include managed care organizations and private insurers. Something to think about. In your local area, are any agencies already partnering in the development and implementation of plans of safe care? How might you partner with these agencies in your current role? Next, let's discuss how plans of safe care are developed and implemented. Remember, a plan of safe care is a document that identifies, lists, and directs services and supports to ensure the safety and well-being of an infant affected by substance exposure, withdrawal symptoms, or a fetal alcohol spectrum disorder, including services for the infant and their family or caregiver. The plan can specify the agencies that provide specific services, outline communication procedures among the family and provider team, and guide the coordination of services across various agencies with the family. The steps shown on the screen outline how such a plan should be developed. First, an infant will be identified as in need of a plan of safe care. After identification, a notification must be made to Childline before the infant's discharge from the hospital. Next, the multidisciplinary team is convened by the appropriate person and the lead entity is determined by the team. This is where you may come in. Then, the plan of safe care is developed in collaboration with the appropriate service partners and put into place. Finally, the services and supports are provided as needed and the plan is monitored by the designated lead entity. The next few slides will dive deeper into the notification and protocols of the plan of safe care across systems. How do we identify which infants and women may need a plan of safe care? An essential first step is through universal screening for alcohol and drug use in pregnant women. Early identification of substance exposure and appropriate developmental interventions improve the long-term well-being of infants. Engaging pregnant women who are using substances in treatment and other services as an element of prenatal care also has strong benefits by mitigating or preventing negative birth outcomes. Universal screening not only identifies women with substance use disorders, but also links them with services at the appropriate level of care. Universal screening reduces the potential for bias and stigma and normalizes the screening process in the same way one would ask all pregnant or postpartum women about the availability of a car seat or a crib for the newborn. The Department of Drug and Alcohol Programs defines screening as the determination of need for emergent care in the areas of withdrawal management, prenatal, or psychiatric care. It is a short series of questions to identify the need for services and determine if further assessment is necessary. It is imperative that pregnant women who screen at risk for substance use be referred for a follow-up drug and alcohol assessment. This allows for more timely interventions and entry into the treatment system to reduce harms for both women and newborns. Just as universal screening for pregnant women will help to identify those in need of a plan of safe care for their infant, so will universal screening of newborns. The Department of Health currently screens all newborns in Pennsylvania for metabolic, endocrine, and hemoglobin disorders, as well as heart disease and hearing loss. To ensure that all newborns are screened to identify substance use exposure, universal substance screening for newborns removes potential bias from practitioners and places the identification of withdrawal symptoms in the context of a medical condition. Universal substance screening for newborns involves monitoring and assessing for signs consistent with withdrawal and scoring each newborn with specialized tools. Two specialized tools that you may be familiar with include the modified Finnegan's Neonatal Abstinence Scoring Tool and the Lipsitz tool. The modified Finnegan's Neonatal Abstinence Scoring Tool is the most widely used tool currently being used due to its comprehensive nature and use for a wide range of substance withdrawal symptoms. The LipSits tool was previously recommended by the American Academy of Pediatrics due to its relatively simple metric and good sensitivity. Both of these tools are available in the public domain, with versions modified to practice needs. It is important to note that both tools were developed for use with full-term infants. Currently, the American Academy of Pediatrics does not recommend a specific tool, but stresses that a chosen tool be used correctly by properly trained staff. Additional evidence-based screening tools are available on the Substance Abuse and Mental Health Services Administration's website. Go to their website, click on Clinical Practices, and then on Screening Tools for more information. What happens once an infant is identified as affected by substance exposure? Pennsylvania's Act 54 requires that the Department of Human Services be notified when a healthcare provider has been involved in the delivery or care of an infant under age 1 born and identified as affected by substances, including fetal alcohol spectrum disorder. Upon determination that an infant has been born affected by substances, the provider will ensure a notification is sent to Childline, Pennsylvania's statewide hotline that accepts referrals of child abuse and general well-being concerns. It is important to note that this notification does not need to be made by the child's specific healthcare provider, such as a pediatrician or other physician. The provider may identify a designated staff person to do so, such as a medical social worker, registered nurse, or patient care coordinator. Childline can be contacted by calling 1-800-932-0313. Providers may also submit the notification electronically at the self-service portal at the link on your screen. Simultaneous with the notification to Childline, the initial team of professionals who will convene to develop a plan of safe care for the infant is then called together. This is referred to as the multidisciplinary team. The multidisciplinary team members who are involved in plans of safe care are individualized based on the needs of the infant or pregnant woman, the mother, and any other caregivers. As with all support plans, the family is a key team member. The team must convene for their initial meeting before the infant's discharge from the hospital, per the law. For infants identified as affected by substance exposure after their discharge from the hospital, the initial multidisciplinary team meeting should take place within 72 hours of the notification to Childline. Who should convene the multidisciplinary team? For pregnant women identified as using substances that may later affect their newborn infant, the healthcare provider or other appropriate staff person, such as a pain management specialist or patient care coordinator, should immediately begin the process of convening all parties that may provide assistance in developing and implementing the plan of safe care for the initial multidisciplinary team meeting. For infants identified as substance exposed at birth, the hospital social worker or other appropriate staff person, such as a patient care representative or discharge coordinator, should convene the initial multidisciplinary team meeting. For infants identified as affected by substance use after their discharge from the hospital, such as through a well-child visit with their pediatrician or an appointment with the mother's OB/GYN, the healthcare provider or appropriate staff will make the notification, and a county children and youth caseworker will be assigned to convene the initial multidisciplinary team meeting. Within this initial meeting, the multidisciplinary team should also determine who to designate as the lead for the development, implementation, and monitoring of the plan of safe care based on the factors of each particular circumstance. Once convened, the lead entity is determined by the multidisciplinary team members at their first meeting. Consider the following populations when determining who should take the lead on the plan of safe care at the initial multidisciplinary team meeting. For the first two populations, the multidisciplinary team should determine on a case-by-case basis who will be responsible for leading the creation and implementation of the plan of safe care. Women who are identified to be in the second population on the screen may need involvement from the County Children and Youth Agency. If the use of medication-assisted treatment or engagement in other treatment is relatively new, the County Children and Youth Agency may need to be involved to ensure the mother continues to be engaged in treatment for substance use and is receiving the support she needs. For the third population, the County Children and Youth Agency should lead the creation and implementation of the plan. In determining the lead entity at the initial multidisciplinary team meeting, the team should also consider the type of substance use or abuse, the impact the use or abuse has on the infant and mother, the safety and well-being of the infant and or other children in the mother's care, and any other needs such as medical or mental health needs, parenting skills, early intervention services, intellectual disability services, or housing stability needs. Not every system will be involved in each plan of safe care, and consideration should be made for the variety of services available through each system. Through education and collaboration, the medical, substance use treatment, and child welfare systems will be able to identify which one takes the lead. All partners at the meeting will work together to ensure potential risks of harm are mitigated, such as immediate housing needs, health insurance, early intervention or intellectual disability services, or other community services. As part of the plan development, the multidisciplinary team should determine how often they meet to ensure that the plan of safe care is being implemented consistent with the needs of the infant, family, and other caregivers. There are no statutory requirements surrounding timeframes for monitoring plans of safe care. Each multidisciplinary team should determine the appropriate intervals at which the team should meet to review the plan and the infant and family's continued need for services and supports. The regular pattern for meetings should be determined based on each individual case, but should be at least monthly. These intervals will likely be more frequent at the onset of a plan and become less frequent as the plan is implemented. Consistent with the individualized nature of plans of safe care, the multidisciplinary team lead will continuously assess each individual situation in order to ensure all of the needs of the infant and family are being met. Some of the partners in the development and implementation of plans of safe care may include the agencies and staff represented on this slide. We've talked about identifying the infant in need of a plan of safe care, notifying Childline, and convening the multidisciplinary team who should partner in the development of the plan. Now we will discuss the development of the plan itself. A key component in developing the plan of safe care is the identification of services and supports that are needed by both the infant, mother, and other caregivers. In order to do this, it is important to be aware of the resources that are available in your local community. Let's take a look at some of the factors the team might think about. Remember, a multidisciplinary approach is vital to ensure families have access to needed services that will help to mitigate risks to the infant and family. Therefore, identifying social services should be the first step in developing and implementing individual plans of safe care for infants affected by substance use and their families. Initial needs identification may include infant health and development, child abuse and neglect risk and protective factors, including any safety concerns, family members and caregivers' needs for substance use disorder treatment, and other health and social service supports in place or needed. Paired with the knowledge of your county's own community service array, this initial assessment will help ensure families' needs are best matched to the appropriate services. After assessing for the individual needs of the infant, mother, and other caregivers, the multidisciplinary team will then begin to plan for services. A well-developed and implemented plan of safe care may prevent the removal of an infant from his or her family or provide opportunity for quick reunification if initial placement away from the family is required. A strong plan of safe care benefits an infant and their caregiver by addressing their treatment needs regardless of immediate child placement decisions. Consider the questions on the screen. Which services could be considered for infants in order to enhance their short-term and long-term health, safety, and well-being outcomes? And what services could be considered for mothers, fathers, caregivers, and other family members? An individualized approach includes engagement of the family system, assessment of strengths, needs, and barriers, coordination and collaboration of systems, resource identification and linkage, and monitoring. Remember, an individualized approach must be given to the development of each plan of safe care. Plans may utilize a combination of services from any or all of these systems: family, medical, substance use treatment, early intervention, mental health or intellectual disability services, and child welfare. It is important to ensure that the family is a partner in the development and implementation of every plan of safe care. The establishment of common goals like health, safety, and well-being for the infant and a supportive recovery system for the parent provide a framework on which the plan of safe care is built and its efficacy determined. Something to think about. In your local area, are there already multidisciplinary teams developing and implementing plans of safe care? In your role, how can you participate in or find out more about what's happening in your county? Finally, Plans of safe care must list and direct supports and services to the affected infant and their mother and other caregivers up to 1 year of age. A plan of safe care should specify the agencies that provide specific services, outline communication procedures among the family and provider team, and guide the coordination of services across various agencies with the family. Plans of safe care address an infant's ongoing health, development, and well-being, as well as the treatment and other service needs of their caregiver and family. They may incorporate services and supports for diverse, longer-term needs, including physical and mental health, substance use treatment, parenting education, infant developmental screening, and other family needs. CAPTA legislation requires that state child welfare agencies report quantitative data related to infants affected by substance use to the Children's Bureau through the National Child Abuse and Neglect Data System to the extent practicable. These data elements to be reported include the number of infants identified as being affected by substance use withdrawal symptoms resulting from prenatal drug exposure or a fetal alcohol spectrum disorder, the number of infants for whom a plan of safe care was developed, and the number of infants for whom referrals were made for appropriate services, including services for the affected family or caregiver. Further, the Children's Bureau directs state child welfare agencies to provide qualitative information in their state annual progress and services report, with details of updates to state laws, policies, procedures, and systems to address the needs of infants born and identified as affected by substance use or withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder, including those related to plans of safe care. That was quite a bit of information to digest in a short amount of time. For more information related to developing and implementing plans of safe care for infants affected by substance exposure, you may refer to the statewide guidance document developed jointly by the Departments of Drug and Alcohol Programs, Health, and Human Services, which will be listed on the Keep Kids Safe website on the Plans of Safe Care page under the Resources tab once released by the departments. You may also contact the Plans of Safe Care resource account at the email address on your screen with any specific questions regarding plans of safe care. For those professionals who will be a part of your local county planning teams, plan to attend one of the upcoming Governor's Institutes for Plans of Safe Care, a hands-on learning experience as you work to develop the county-level policies and protocols needed to successfully implement plans of safe care for infants and families in your communities. For information on how your local county planning team can register for an upcoming Governor's Institute, visit the Keep Kids Safe website. Thank you for joining us for this webinar on Pennsylvania's support for infants born substance exposed and their families.